level. Yeah. Good evening to whoever has joined us. It's 4:30. We are starting the class. Today is 23rd November 2020. I'm Dr. Prithika Chary. I did my MBBS between 1966 and January 1971 in Kilpauk Medical College. After that, I did my MD, DM, PhD, and MCH from Madras Medical College. I completed my MD in 74, my DM in 78, a PhD in neurology in 1981. I was the first person in Madras University to do a PhD in neurology. And I'm also the first person to have done, in addition to my DM neurology, which is a medical degree, I went back in 1986 and did an MCH neurosurgery as well. And these are my qualifications. I was conferred the MNAMS in 1989. So all of these are academic qualifications which I got in the first attempt. And as you can understand, I enjoyed learning. And I would encourage all of you as medical students, throughout your life, please remember, you never stop learning, because this is a field of practice that we have all chosen our careers in, where you will have to keep learning all the time because knowledge keeps changing all the time. I was a consultant neurologist in Apollo hospitals from 1983 to 2012, prior to which I did 8 to 9 years as an assistant professor in Madras Medical College. I've been with Kaveri Hospital from 2012 to date. Now, is this how you feel when you are presented with a case of aphasia? Yes or no?
Yes, ma'am.
Because for all of us, even at our stage of training, even with DM neurology, you feel, tale pichikinume kind of feeling you get when you come to aphasia, because everybody makes it so complicated. So what I'm going to try to do for you is give you a little background. I will pause in the middle of the talk. And if you have any problem understanding, please put it. I can't see the chat, but one thing, but maybe Fida can interrupt me and on your behalf and tell me. And I will repeat the thing, because the intention of these classes, especially for final year MBBS, is for you to understand the subject and be able to face it in the exam.
Yes, ma'am. Ma'am, I'll just request the host to enable the chat for
Yeah, sure.
Rahul, the chat is only for lecture hall. Okay, yes, ma'am. The chat has been enabled, ma'am. If there's any question, they'll be texting it in that.
Yeah. Now, we feel that in the evolutionary progression, the human being has been given the facility of language. Other animals communicate with each other by various means, by sounds and grunts, and the dolphins and all that. Dolphin communication is considered to be pretty high, but it does through ultrasound. Now, we are the only creatures who are given the privilege of having language. Now, what do we use language for? We use language for communication. We also need it for cognition, which is understanding and making meaning of the world around us. It also influences our behavior. Luria was a person who he's a Russian scientist who worked on aphasia for a long time. And he has felt that it also influences human behavior. We know that language influences human behavior. In 1973, Lewis said that it also is necessary for us to put things into the memory. And there is a difference in the definition between language and between speech. Language includes all the cognitive processes that affect communication. And it's an integration of the verbal, the visual, and the auditory response. Whereas when we say speech, we are talking more about a peripheral thing. So language requires the cognition, so it's more a central aspect. Speech is articulation, the way you pronounce the words, the phonation, the sounds that we make in order to produce an acoustic symbol which will enable us to express our thoughts. So when we talk about aphasia, we are talking mostly about a language disturbance rather than a primary speech disturbance, but the cognitive processes in the brain control also the peripheral mechanism, and so the two are tied up together. If we look at the history of aphasia, people described an aphasia after head injury way back in 2000 BC in the Egyptian hieroglyphics. In Greece and Rome, there were speech handicapped people who were identified. Hippocrates called what could have been a vernix aphasia as cluttering, where a person was saying a lot of meaningless things. Aristotle said there is a brain center for speech. So he said that what we are talking is coming from the brain. The peripheral mechanisms were described by Celsus. And Leonardo da Vinci was the first person who actually described the physiology of speech and the way we produce the voice, and he described the vocal cords and all the peripheral apparatus of speech. Then we had identification of stammering, but the real identification of aphasia happened only in between 1796 1881 at this stage, when this gentleman localized the speech to the frontal lobes. Then there were two brothers, pair and Fee, who described that handedness has something to do with cerebral dominance, and cerebral dominance has something to do with speech. And this was way before Broca, 30 years before Broca. Then Henshin described what could have been a sensory speech disorder, and Lippmann identified that there is a movement disorder which happens, which interferes with language, but which is different from aphasia, and he called it apraxia. We'll be expanding more on. But the real localization of speech and language to a brain area was done by Paul Broca in 1861. There were two people who he did the autopsy on, and he found that both of them had a speech disability, and both of them had lesions in the left, second, and third frontal convolution. And this was called Broca's area. And the speech disability which they had was called as Broca's aphasia. Carl Wernicke later on went on to describe that the cerebrum is divided into an anterior motor area and a posterior sensory area for speech. And he described different types of aphasias, where he described that the anterior motor ones were more problems of expression, and the posterior sensory area was more problems of understanding or comprehension. Jackson said he did not agree with either Broca or Wernicke, and he called them the diagram makers. He said speech is something more innate. We develop by our thinking process an inner speech, and then we give it an output, that there is no specific area for speech. Then there were a lot of people after that who worked on aphasias and speech disorders. It was as late as in the early 1900s that 4 types of aphasia were described. They described a verbal aphasia where the speech output could not say words. They described a syntactical aphasia where the grammar was all wrong. They described a nominal aphasia where you could not get the correct name for an object. And they described what is called as a semantic aphasia, which was an understanding issue. So there was no distinction as expressive and receptive, but it was more related to the manifestation of the speech disorder. But in the 20th century, a lot of good work was done, and these were the authors who carried out all that. And among these, both Geschwind, Critchley, Geschwind, and Penfield are of, and Luria. They have done the maximum work which has given us the information that we have today. The basic neuroanatomy for aphasia is that the Broca's area is responsible for expressive speech. The Wernicke's area is responsible for receptive speech. The connection between the Wernicke's area and the Broca's area, called the arcuate fasciculus, is responsible for repetition. And a part of the gyrus, which is sitting at the cleft of the sylvian fissure, is responsible for reading and writing. This is the very basic anatomy which you have to remember. We'll be talking of this in greater detail, but please understand that if you don't know this, you can be failed. So this is something that you have to know. Now, the neurophysiology, if we look at it, there is the central component. The language area is largely in the left side of the brain, and it occupies an area around the sylvian fissure. So it is the left perisylvian region. There's a peripheral component, which is responsible for the articulation, for the phonation, for the resonation, and the respiratory elements of speech. For the articulation to be okay, you need to have your palate, teeth, mouth, and lips should be normal. The phonatory resonatory apparatus is the nasopharynx, the oropharynx, and the laryngopharynx. And the respiratory component are the muscles of the chest. So there is a central component for the neurophysiology and a peripheral component. Now, if you look at the central component, Broca's area is here in the frontal cortex. Wernicke's area is in the posterior temporal, upper temporal cortex. The angular gyrus is here, just like a curve around the sylvian fissure. There is a gyrus just near the angular gyrus called the supramarginal gyrus, which also is involved in the reading writing. There is a gyrus within the sylvian fissure called the Heschel's gyrus, which also plays a role in the comprehension of speech. And you'll notice that this entire perisylvian region also encompasses the motor component and the sensory component of the oral part of the motor cortex and the sensory cortex, this area. So you'll notice that in the motor cortex, this area represents the lips, the jaw, the tongue, and the throat. So the Broca's area is very close to this part of the motor area. And the Wernicke's area is very close to the auditory cortex in the temporal lobe. So the motor projection areas of the motor cortex are related to speech, and the auditory cortex projection areas are related to understanding, hearing, and understanding of speech. Now, if we go a little deeper, we'll find that there are connections in both directions between the Broca's area and the Wernicke's area. There is a connection between the angular gyrus, the auditory association area, the Wernicke's area, the supramarginal gyrus, orofacial motor cortex. So all of these are connected. And in addition to this, the premotor cortex also plays a role in the control and physiology of speech. For instance, a lesion in the thalamus can also cause a type of aphasia. So for coordination of speech, for coordination of the peripheral speech apparatus, we need the cerebellum, we need the thalamus to have the sensory inputs, we need control by the extrapyramidal system, the pallidum, and the supplementary motor area, and the somatosensory cortex. All of these also are connected and play a role. So we have the frontal lobe, the parietal lobe, the temporal lobe, and a little bit of the occipital lobe, which I will show you how the occipital lobe gets connected. You have what is called as the visual association area, the auditory association area. All of these work together with the vernix area for us to be able to read, write, and understand the spoken word. So this is very important to remember. Then the frontal eye field also has some connections with the prefrontal area and the Broca's area and the motor area for the oral apparatus. What are the structures in the peripheral mechanics of speech and its central control? You'll find that the nasal cavity, the hard palate, the soft palate, the tongue, the pharynx, the larynx, all of these, the vocal cords, all of these are involved in the production of speech. And all of them have a central control in the brainstem. So the brainstem structures, together with the cerebral structures, play a role in the output, understanding, and ability for us to convert language into speech. So let us do a recap. So we've got the Broca's area, we've got the premotor cortex, we've got the prefrontal cortex, we've got the primary auditory cortex, we've got the brain stem, the cerebellum, the optic radiation, vernix area, the gustatory area, the parietal lobe, primary somatic sensory cortex, which gives you color, etc., color recognition, object recognition, etc. So though the perisylvian region is the main language area, there is a lot of area around it also, which plays a role in language and speech. Now, what is the next important thing we have to understand? If you look here, the main arterial supply for all these areas is the middle cerebral artery. So the commonest conditions which produce a speech and language deficit or an aphasia is related to supply from the middle cerebral artery. And when we look at the arterial circulation of the brain, including the carotid arteries, we will find that more than any of the other arteries, the main artery involved in speech and language control is the middle cerebral artery, and on the left side. Now, what happens when we hear a spoken word? The auditory cortex assimilates the spoken word. The vernix area gives it understanding. The arcuate fasciculus carries that understanding and goes to the Broca's area. The Broca's area develops the capacity to express it, and it uses the motor cortex and the motor speech apparatus in order to produce the word. So to do this, you have to first be able to see or hear whatever it is. If it's a reading which you're converting into a spoken word, or whether it's something you heard which you convert into a spoken word, you have to use vision or you have to use hearing. And then only this processing can occur. This is a very simplistic model, but it is adequate for you to understand, because I think you'll get the gist of it, that while it's perisylvian, that there is a whole wide network around it. In Brodmann classified the areas of the brain, and Broca's area got the number 44. So Broca's area is number 44. The auditory area is number 41. The angular gyrus is 39. And the sensory motor cortexes. But nowadays we don't use the Brodmann's classification. But still, for some reason, this area 44 has stuck. And very often you'll find Broca's area referred to as area 44 in some of the literature that you may read. Now, what is the commonest cause of aphasia or an aphasic syndrome? Very often you need to elicit in a patient who presents with aphasia a history of hypertension, maybe a previous brain hemorrhage, cardiac disease, carotid disease, intracranial vascular disease. But commonly, aphasia and related disorders occur due to stroke, a head injury, cerebral tumors, or in degenerative diseases. But the most common cause of aphasia, and which is 20% of stroke patients, especially if it's a left-sided brain lesion or a left-sided stroke, they present with aphasia and a right hemiplegia. Now, there are a lot of standardized tests available for testing aphasia. I'm just mentioning the names, and I'm going to just give you the pros and cons a little bit, very briefly. Now, there is a standardized test called the Western Aphasia Battery. The advantage of this is it gives you a classification of the type of aphasia. It divides it into global, Broca's, isolation, transcortical, sensory, conduction, and anomic. But it doesn't give you a comprehensive coverage. There is another test called the Boston Diagnostic Aphasia Exam. This one gives you a severity rating scale, which is advantageous, which is a profile from, is it mild, moderate, severe, which is useful. But a very quick test is what is called as the Porsche Index of Communicative Ability. But in order to conduct this test, the person who does the test has to undergo more than 80 hours of training. So what we do is normally we just leave all this to the speech pathologist to do. It's very good because it has a multi-dimensional scoring system and it gives a very accurate and reliable measure of the patient performance. Now, there are some problems when it comes to a patient presenting with a speech disability. A person with aphasia sometimes cannot provide the complete history because of his speech disability. And the clinical information, therefore, has to be partly from the family members. And in a head injury or a stroke, aphasia occurs abruptly. And there is absolutely, some of the patients have no speech at all when they present to us. But remember that if it is a neurodegenerative disease or a tumor, the aphasia is likely to occur very slowly and insidiously over many weeks, months, or even years when it comes to Alzheimer's and things like that. So a little tip in the history is, if it's a sudden speech disability, it's likely to be due to a stroke or a head injury. If it has come on a little more slowly, it is likely to be either a mass lesion, which is slowly expanding, or it's likely to be a neurodegenerative background illness. Very rarely, there is some focal encephalitis, like herpes simplex encephalitis, which can cause a relatively subacute or acute aphasia. And it's a treatable condition. There's a very short window for diagnosis. But the clues here to diagnosis will be there'll be a history of fever, seizures, headache, behavior changes. It's a subacute illness, and headache, acute or chronic, may also be associated. So also you may get headaches in arteriovenous malformations and brain tumors, which can create a subacute onset of an aphasia. So it's very important for us, when we get the history, to ask about memory impairment and difficulty in performing activities of daily living at home prior to the language dysfunction. That may tell us that it's neurodegenerative and not an acute stroke-related problem or issue. So what is the examination of a patient with aphasia? We naturally have to do a mental status because we need to test the memory, orientation, intelligence, and the psychological state of the patient before we launch into an examination of aphasia. Memory is the ability to register and recall a prior sensory input. Now, a person with aphasia doesn't have a memory disorder necessarily. They're just not able to voice out or produce or process the language and bring it out. But it's important for us, if possible, to test memory. Now, how do you test memory in a person who's not speaking? Because many of our memory tests, like we have, you can do simple memory tests by showing objects and asking them to pick out the right object. So that is a simple way of testing memory without having the patient having to talk. You must also remember that memory can be impaired in any kind of encephalopathy. So you have to be a little careful. So test the memory, but don't make a judgment. Orientation. If the patient is mentally confused, it's very difficult or impossible to test a patient for aphasia. And orientation means an individual's cognitive sense of his status in time, place, and person. So you need to be sure that the patient is fully oriented before you can launch into testing aphasia. And this is the reason why very often aphasia testing is not done when you first see the patient. It is done a few days later, once the stroke or the head injury stabilizes, when all these other functions are stable, and then you can start the aphasia testing. When a patient who does not know who he or she is, but if he can tell the time and is oriented in place, think if there is a psychological condition. Because they will not be oriented in place if they are pathologically having a disorientation problem. I'm not going to go into great depth in mental status testing, but I'm just briefly telling you. Intelligence is the ability to apply prior knowledge quickly and successfully to a new situation, to use reason in solving problems. Please understand that intelligence is not necessarily related to literacy. A person can be illiterate and can be intelligent, like a farmer, for instance. Take a farmer, he knows when to sow the soil. He is much wiser than you in a lot of farming aspects. He can be highly intelligent, but he may be illiterate. So literacy and intelligence are not equivalent. When we say IQ, we assume that literacy and intelligence are equivalent. They are not necessarily equivalent. Then a brief idea about the psychological function has to be checked. Now, before we get into aphasia testing, another very, very important thing we have to test is, can the person see? Because some of your tests are going to involve using vision. Can the person hear? Now, this hearing and vision, please understand, especially after a stroke, they can also be central. For instance, a person may say, I cannot see, but will be able to go about on his own without any problem if he has cortical blindness. A person may say they cannot hear if they have a lesion in the auditory cortex, but hearing is not so impaired so difficult to manage as vision. So in cortical blindness, especially bilateral cortical blindness, they may not be able to, they'll complain they cannot see, but they will be able to move about because primary vision is intact. The same with hearing. We also have to examine the speech apparatus. We have to see if the tongue is okay, the palate is okay, the teeth are okay. We have to check their motor coordination, the cerebellar function. And we have to look at the lobar functions, because associated conditions like agnosia, apraxia can modify the interpretation of the aphasia. Now, we told you that beside the perisylvian region, there are a lot of other areas. So you may get certain neighborhood signs from the adjacent cortical areas. There can be difficulties with vision, like hemianopia. There can be deficits of motor or sensory function. Now you will understand why that slide which I showed you earlier has meaning of what is the nearby area to that perisylvian language area. There can be neurobehavioral deficits like alexia, which is difficulty in reading, agraphia, difficulty in writing, acalculia, difficulty in calculation, or apraxia, in difficulty in recognizing certain motor activities. Also, remember that sometimes in epilepsy, they may present with an aphasic, temporary aphasia during a seizure. So we should also get an indication if there are subtle seizures like staring spells, automatisms, or any previous aphasic episodes, because temporal lobe epilepsy can present as speech errors or confused garbled speech. So that can be mistaken for recurrent aphasia. The next thing that we have to examine is that there is a cerebral dominance when it comes to speech and language. In general, the cerebral hemispheres are equipotent, but in higher primates and in man, the left hemisphere is dominant and controls the verbal processes and higher cognitive processes associated with speech. The right hemisphere is non-dominant. It is the minor hemisphere, but it has a role to play in speech and language because it controls the spatial, visual, and constructional tasks. Now, when we do an aphasia testing, we always test drawing, we test their ability to map read or a visual spatial task. We do that. So we need to realize that that is important. And we know that handedness has a connection to cerebral dominance. Majority of the population is right-handed. They are called dextral. It's a Mendelian dominant. 1 to 30%, actually they say about 12%, is left-handed, and a left-handed person is called a sinistral. This is a recessive trait. There are a few people who are equally proficient with both hands. They're called ambidextrous. Or they're equally clumsy with both hands when they're called ambilevous. Now, the left hemisphere is dominant for speech in both the right-handed and the left-handed person most of the time. But in few left-handed people, it can be the right hemisphere which is dominant for speech. Language in general is bilaterally distributed, especially in the left-handed person. Now, this is very useful when it comes to aphasia because when they get a right hemiplegia with aphasia, they are more likely to recover their speech, and they're also more likely not to get an aphasia with a right hemiplegia. And in general, the aphasia tends to be less severe and recovery is far better in a left-handed individual. So language function in 96 to 99% of right-handed and 60% of left-handed people is lateralized to the left hemisphere. Now, when we look at disorders of speech, we have to see if it is one of these four things. Is the speech disorder actually a disorder of cognition, and is it a dementia which is manifesting with the language disturbances? Is it a dysphasia, which we are going to discuss in detail? Is it a dysarthria? Now, dysarthria is an inability to enunciate speech. Now, a dysarthria can be a peripheral dysarthria or a central dysarthria. It can occur due to a bulbar palsy, due to a pseudobulbar palsy when the palate is a bulbar palsy, the nerve supply to the palate is affected and it is actually paralyzed. So swallowing will be impaired and speech will be impaired. The pseudobulbar is when it is a upper motor neuron lesion of the same muscles of the swallowing, and extrapyramidal you can get like in Parkinson's, etc. Then you can get facial causes, like after facial palsy, there may be a dysarthria. Stuttering is a dysarthria. In Parkinsonism, you can get dysarthria. In cerebellar lesions, you can get a dysarthria. Now, dysphonia is a loss of voice volume. And this is always due to a vocal cord lesion. So, dementia means there is a primary mental disturbance. Dysphasia is a language disorder. Dysarthria is an inability to enunciate speech. And dysphonia is a loss of voice volume. So when you see a person with a speech disability, you just classify it in your mind. Is it one of these four? If it's a dementia, you're going to examine it differently. Dysarthria, you need to check out all these things which I pointed out. Dysphonia, you automatically have to verify if the vocal cord function is okay. Because in dysphasia, you may not get any of these. But in a stroke, remember that the corticospinal fibers are affected The corticobulbar fibers also are affected. So you may get a bulbar palsy with an aphasia and a hemiplegia. So you need to be alert on all of these aspects. Now, before I go on to aphasia proper, can I get some interaction from you people as to, have you understood the primary background for aphasia up to now?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Okay, fine.
Ma'am, there was
Yeah,
one doubt in the chat box.
sure.
Can a
Tell me.
brain lesion present as aphasia?
Sorry?
Can a brainstem lesion present as aphasia?
I told you, no, that there are connections with the thalamus and pallidum and this thing. So there is no, there is actually an entity known as a thalamic speech disorder. It is an expressive speech disorder, and that's due to the connection with some of the brainstem. But a brainstem lesion will affect more the peripheral apparatus. Like I told you, bulbar, pseudobulbar, those things. You don't get an aphasia proper with a brainstem disorder. Is that okay?
Yes, ma'am. Thank you.
Hello? Yeah, okay. Okay, now we'll go on to aphasia proper. It's an acquired disorder of language due to brain damage. So there are other purely motor speech disorders, which can occur with brainstem disorders, by the way. But they are more limited to articulation of speech, like stuttering, dysarthria, apraxia of speech, etc. Aphonia, I've already told you, or dysphonia is a loss of voice volume. Now you must remember that aphasia sometimes there are associated disorders which can occur with it. In general, when we say aphasia, we are talking about disorders of spoken language and disorders of written language. Now, some of the disorders of written language may be selective. It may be just a disorder of reading. Now, you all have to know these names. So if they're available in all the standard textbooks, but you have to know what is alexia, what is agraphia, etc. Alexia is a disorder of reading. Agraphia is a disorder of writing. And closely associated to aphasia, you have certain other disorders, which are called the apraxias, which is a disorder of learned or skilled movements. I'll be dwelling a little bit on apraxia a little later. Agnosia is a disorder of recognition. In your textbooks, it'll be quite confusing. So my suggestion is that you better note this down, because it's a very, very simple way of remembering it. And this you just have to mug it up. Acalculia is a disorder of calculation ability. I've told you the global neurobehavioral dementia and delirium, you don't worry. You have to remember this. Alexia is disorder of reading, agraphia of writing, apraxia disorder of learned or skilled movement, agnosia is a disorder of recognition, acalculia is a disorder of calculation ability. We told you about dysphonia, but I'm not going to spend longer on this. This can occur in a unilateral recurrent laryngeal nerve paralysis, any lesion of the vagus nerve, and it's almost always associated with a hoarseness of the voice. And you can get this even when we do for epilepsy, we do vagal nerve stimulation implant, and sometimes they'll complain of hoarseness of voice. Dysarthria, I told you, is the inability to articulate spoken words. So this is due to paralysis of either the pharyngeal, the palatal, lingual, or facial musculature, and control of these musculature, which we saw in the peripheral apparatus central control. Now we have to go to the aphasia syndromes. Now it's very confusing. Most people have a problem here. They get quite frustrated by the time they go through the aphasia syndromes. But I want you to remember three important things. One is abnormal language expression. The second is repetition. The third is comprehension. So just keep those three things in your mind. The aphasia syndromes are described as being either perisylvian, or non-perisylvian. So the perisylvian ones are the ones that immediately surround the sylvian fissure. The lesion is in the areas immediately around the sylvian fissure. So what is the speech and language area there? Is the Broca's area. So you have a Broca's aphasia. You have the Wernicke's area there. Remember that always when you do this, remember the anatomy. Then you will find it easy to remember. The Wernicke's area, there's something called conduction aphasia, which we'll talk about later. And when all of this is involved, it's called a global aphasia. Very simple. Now, what are the non-perisylvian aphasias? There is something called as anomic, where they cannot name an object. Now, this has no localizing value, but it's a type of aphasia which exists. So you need to know it. Then you've got what is called as transcortical motor. So now supposing this is the perisylvian region, and the region above that is close to the motor area and the lesion is there, then it is called a transcortical motor aphasia. If it is closer to the sensory cortex, it is called a transcortical sensory. And you can get a lesion which encompasses both the motor and sensory cortex, and it's called a mixed transcortical. Beyond this, you have specific language syndromes, which we are not going into detail and which you need not know for the final year MBBS level. You need to know it if you are going for MD exam. Or they are associated with what is called as ephemia. You get alexia, that is, you can have a reading difficulty with or without a writing disability. So it's alexia with and without agraphia. Or you can get what is called as pure word deafness. Now in pure word deafness, it's the auditory cortex which is where the lesion is. And I told you, the person will complain they cannot hear. But actually the hearing apparatus, if you make a loud noise behind, they'll jump. But if you talk to them, they say, I'm sorry, I can't hear you. That is called pure word deafness. Then you've got certain syndromes which occur in the subcortical area. Now you've got the sylvian fissure, the perisylvian area, the area around the perisylvian area, and in the depth of the Heschel's gyrus and in the subcortical regions, you can have syndromes. That is when the thalamus, pallidum, etc. get involved in the subcortical aphasias. So what are the aspects of speech that we will check? The first thing that we always, which you'll find very easy to classify the aphasias, is the fluency. Is the person speaking fluently like we are speaking now? Or is they talking like that, non-fluent? Because straight away, non-fluent aphasias are anterior and fluent aphasias are posterior to the sensory motor strip. So straight away, you are beginning to get some localization. The word output is important. Do they initiate speech? Are there difficulties where they pause and say they're not able to get the right word at the right time?
Excuse me, ma'am.
Are there, yes?
Ma'am, can you repeat the part you said about fluency?
Okay. If a person is non-fluent means this, I am, that is non-fluent. Okay? What I'm talking is fluent. If it is non-fluent, the lesion is anterior to the sensory motor strip. If it is fluent, the lesion is posterior to the sensory motor strip. Is that, are you clear now?
Yes, ma'am.
Okay, fine. No, the idea of aphasia is you have to learn to localize the aphasia. Now the localizing is beginning at this stage. The first localization is it anterior brain or posterior brain? And in aphasia, you may get what are called as paraphasic errors. Now these paraphasic errors may be a word substitution. They put a different word for a particular word. For instance, there are varieties of paraphasias. It's not really important or critical for you to know, but if it's semantic, if it is related to the meaning, they will say fork for a spoon. It may be phonemic, it may be the sound of the word. When they'll say poon instead of spoon, this is, you just have to note if there are a lot of paraphasic errors or few paraphasic errors, because when you go into detailed localization of speech, it helps. But I think at your level, it's not very necessary. It's enough if you observe that there are paraphasic errors, and if you observe whether they are related to meaning, which is semantic, or whether they are related to sound, which are phonemic. Then you have to also say if there is an associated dysarthria. This is a consistent mispronunciation of the phonemes or the components of a word. Apraxia of speech is an inconsistent phonemic errors, often at the beginning of a word. We won't go into that too much now. I'll talk about apraxia later. Then the next thing that you notice about the speech is what are known as abnormalities of prosody. Now, prosody is the rhythm of speech. Now, if I lose the rhythm of speech, I will be saying dysarthria, consistent mispronunciation of phonemes, apraxia of speech, inconsistent phoneme, errors often at the beginning of a word, abnormalities of prosody, the emotional intonation of speech, often abnormal with right hemisphere. There is no rhythm, there is no intonation. And you'll find that there are rhythm disturbances in the speech if it is a right hemisphere disorder more frequently than in a left hemisphere disorder. So we have noted the fluency. Next week, notice the rhythm of the speech. Then we go on to the expression of the speech. Now, are they able to spontaneously talk and give you the history, for instance? Are they able to express themselves? And when they are expressing themselves, are they having word finding difficulties? Are they having paraphasic errors? Are they dysarthric? Are they mispronouncing words? Are they fluent? Or are they, does their speech have rhythm? All of these you will observe when a person is talking to you. Then you will say something and ask them to repeat after you. Then you will say something and ask them to carry it out. So you want to know, do they understand your oral instruction? After spoken language, if the person is literate, you will go to testing written language. And then you will have to test the associated conditions, which are agnosia, apraxia, etc. So let us take each of these one by one. Now, if you take the categories of aphasia, please, I'm sorry about this slide, it's a bit busy. There are 4 broad categories. Expressive aphasia, receptive aphasia, anomic or amnesic aphasia, and global aphasia. Very simple. So in expressive aphasia, they find it difficult to convey their thoughts either through speech or through writing. In receptive aphasia, they find it difficult to understand either spoken or written language. In global aphasia, there is extensive damage in the brain and all the language areas of the brain are affected. In anomic or amnesic aphasia, they cannot use correct names. They find it difficult to name an object or a person or a place or an event. Now, out of these, this anomic aphasia is an entity I told you earlier, but it doesn't have any localization value. So let's put all this into a simple table. I told you fluency is very, very useful for us to classify. So if it's non-fluent, it is anterior part of the brain, Broca's aphasia. Wernicke's aphasia is a fluent aphasia. Broca's aphasia is an expressive aphasia, and so understanding is intact. Wernicke's aphasia is a receptive aphasia, so understanding is impaired. Naming can be impaired in both. The localization for Broca's aphasia is Broca's area. For Wernicke's aphasia, it is Wernicke's area. Then I told you there is something called the conduction aphasia. In conduction aphasia, it is the connection between the Broca's and Wernicke's aphasia, the arcuate fasciculus. Here, understanding is intact, but they will find it, they will have a speech disability. They will not be talking. They're not very fluent. They don't talk at all. They don't name, but they have a speech disability, which is a conduction aphasia, but they have full understanding. In global aphasia, understanding will be impaired, and it involves both the Broca and the Wernicke areas. So I think this is now simplified. So we went from fluent or non-fluent, anterior or posterior, Broca's area or Wernicke's area, expressive or receptive, is naming intact or not. And up to now, we have got some degree of localization with this amount of examination. Now, I'm not going into multilingualism, though this was the basis of my PhD thesis. We now move to the next very valuable localizing test, which is repetition. Now, in all the perisylvian aphasias, which are the perisylvian aphasias? Broca's, Wernicke's, global, nominal. Repetition is abnormal. In the non-perisylvian, which surrounds, that's the transcortical aphasias, repetition is preserved. And this is a very useful test. So we have checked whether the person is fluent or non-fluent. We have checked whether the person is able to, is it expressive or receptive? Is comprehension intact or not? We have got some degree of localization, anterior, posterior. Now we know, we go off the aphasia, is it perisylvian or is it beyond that in the association areas? So it's very easy actually. So we'll now go to the 4 types of repetition. In transcortical motor aphasia, that is the area which is anterior to the Broca's area, repetition is intact. In Wernicke's aphasia, repetition is intact. In transcortical sensory aphasia, which is posterior to the Wernicke's area, you'll find that it is intact. But transcortical mixed, I'm sorry, that was wrong. Repetition is preserved in Broca aphasia. It's preserved in Wernicke's aphasia. But it can, I'm sorry, that's a mistake. This slide itself is wrong. Remember it this way. In the transcortical aphasias, repetition is preserved. In Broca's and Wernicke's aphasia, repetition can be affected. Sorry, that was a mistake slide itself. Now we'll go to each of the aphasic syndromes. What happens in Broca's aphasia? Sorry, that was an error. Repeat it again.
Yes, ma'am. Ma'am, actually one confusion. Ma'am, you said lastly that in Broca's and Wernicke's, it can be affected. So it need not always be affected.
Need not always be affected.
Okay.
It can be affected, but usually all the perisylvian repetition gets impaired.
Okay.
Because for instance, in Wernicke's, the reason why repetition will be impaired is he cannot even understand you. In Broca's, they can't express it. So there again, repetition will be impaired. Whereas that's not there in the transcortical. We'll go over it one more time.
Yes, ma'am.
Don't worry.
Okay.
I'm sorry that I confused you because that slide was wrong. Now, in Broca's, the verbal output is deficient, expressive aphasia. Ability to repeat sentences is impaired. So repetition is impaired. Got it?
Yes, ma'am.
Yes or no? Got it? Repetition is impaired because they can't say it. No. Common sense. Comprehension is normal. Understanding is normal. Naming of objects will be marginally impaired because they're not able to say it, not because they don't know. And sometimes they don't find the right word to say it. They have word finding difficulty. The associated clinical signs that they may have is a right hemiparesis and apraxia of the left-sided limbs and face. I want you all not to break your head too much about the apraxia part right now. Just remember the aphasia part of it. And it is in the left hemisphere and it is in the Broca's area, the lesion. The Wernicke's aphasia is a fluent aphasia. Ability to repeat a sentence is impaired. Comprehension is impaired. The naming of objects is impaired. And there may be an associated right homonymous hemianopia because it is in the upper posterior temporal lobe. And the visual fibers go there in the temporal lobe. So you may get a right homonymous hemianopia. And the lesion is in this area of the brain, the Wernicke's area, and maybe in the angular gyrus and the supramarginal gyrus. In conduction aphasia, it's a fluent aphasia. Ability to repeat a sentence is impaired. Comprehension is normal. So the difference between a Wernicke's aphasia and a conduction aphasia is in the understanding part of it. Otherwise, they're both the same. Look, they have the same features. So Broca's understanding is normal. Wernicke's understanding is impaired. Conduction understanding is normal. And even in a conduction aphasia, you may get a right hemisensory deficit. You can get an apraxia of all the limbs. The lesion, as you see here, is more on top here rather than here. It is the arcuate fasciculus. Are we clear so far?
Yes, ma'am.
Because we're not going to run through this again. You need to remember, and these are something that you just have to remember. Then we go to the global aphasia, where word output is deficient, their ability to repeat is impaired, their understanding is impaired, their naming is impaired, they have a right hemiparesis and a right hemisensory deficit, they may have a homonymous hemianopia, and the lesion is fully in the perisylvian region. Now in anomic aphasia, there is a lot of controversy whether there is a localizing area. But there is, though they have showed a picture, in the picture here, they've showed a lesion here, there really is no clear localizing area that you can identify. And in anomic, it's a fluent aphasia. They find it difficult to repeat, but they can name, they won't name an object, but they can repeat after you. There is no understanding problem. And the naming is impaired. Naming is the main deficit. And there is no other associated condition. That is why it is non-localizable. Then you go to transcortical motor, where word output is deficient, like a Broca's aphasia. Then you will find that the ability to repeat is normal. Their understanding is normal. Their naming of objects may be impaired, but again of non-localizing value. And they often have a right hemiparesis. In transcortical sensory aphasia, it is a fluent aphasia. The sensory aphasias are all fluent, remember that. The motor ones are all non-fluent. Their repetition is normal. Understanding could be impaired. Naming could be impaired. And they may have a right homonymous hemianopia. Now, if all of you are comfortable with this table, we will be finishing the aphasic syndromes with this. So if you want it to be repeated, or if you want me to show it once more, I'll show it once more. So these are the first three main aphasias and their localization and the impairments. And these, with this, all the aphasic syndromes that you need to know for the exam are done.
Ma'am, we can proceed. I think it's needed.
Right.
Ma'am, 1 second.
So this is again another summary. Yeah, tell me.
Ma'am, the doubt is like if transcortical motor affects, one second, ma'am, I'll be checking it. If transcortical motor affects fluency, how is repetition intact, ma'am?
No, no, it may be impaired is what we've said. No. Transcortical motor, wait, I'll go back. See, transcortical, normal in the sense, it's not so severely affected. It's not the motor part which is affected. It's only the association fiber. Word output can be deficient. That is the difference. That for some reason repetition remains intact in all the transcortical lesions, whereas in the perisylvian lesions repetition gets interfered with. But it's a good question. But it's the fibers which are underlying. The motor component of the motor cortex remains intact. Is that okay? I know it's not a very satisfactory explanation, but it's a fact. And it's useful for you to make a diagnosis and get a localization. It can be impaired a little, I guess, but not to the extent that you'll find with the brokers.
Yes, ma'am.
You see, here it says, even here, it says in global, where is that? Yeah, transcortical sensory also, it is normal. But in transcortical motor, you got a point there that it could be a little impaired, but it won't be striking. Repetition will tend to be mostly normal. Spontaneous output will be deficient.
Okay.
Okay, now this again summarizes, but I'm not going to confuse you with this slide because it includes pure word deafness, alexia, and all of the other stuff. Now, what is agnosia? You need to understand what is agnosia. It's just an inability to recognize. And this inability to recognize could extend to an object, to people, to sounds, to familiar sounds, familiar shapes, familiar smell, familiar person, object, or even a familiar stimulus. So how do you, it's complicated to examine a person for agnosia. You just have to ask them, what is this? And they will be unable to recognize, but they will be able to use it. Now, the usual example that is given is that I may take if I'm a smoker, I may take a cigarette and light up. But when asked, what is this? What did you just light up? What is it? I will not be able to tell you it's a cigarette. But I'll be able to use the object. I know its utility, but I will not be able to recognize it and tell you what it is. There are three main forms of agnosia: visual, auditory, and somatosensory. Visual is the person has difficulty in recognizing an object, face, or word. So when they have agnosia, any aphasia testing that you're trying to do, like naming, you cannot do object recognition in naming objects. You cannot do that part of the test. It won't work. They will not be able to recognize words. So even if they're literate, you may not be able to do any reading related tests, reading or writing tests. They may not be able to identify or name a picture. So you may not, it may interfere with aphasia testing. Auditory agnosia is the inability to recognize sounds. So that also to some extent may interfere, but usually doesn't interfere too much with aphasia testing. Somatosensory is when the person has difficulty in perceiving the object through tactile stimulation. So when you're doing a routine neurological exam, you may get a difficulty when you're doing the sensory testing. Apraxia is a kind of poor coordination. It's an inability to perform a skill action, like I said, like lighting up a cigarette, etc. They may spontaneously light up, but if you ask them to light up, they will not be able to light up. Its inability to perform a purposeful action. It's a discoordination between the ideation and the motor pattern. So they cannot you give them blocks and ask them to assemble it, they will not be able to do that. And this can cause problems in speech because the ideation of what I want to say may not come out right the way I want it because of this apraxia. Now, apraxia is localized to the inferior parietal lobule of the left hemisphere. And there are a lot of disconnections and lot of disconnection symptoms. And they can have specific types of apraxia called dressing apraxia, where in a right parietal lesion, it's part of neglect. When you get a parietal lobe lesion, what happens is they tend to neglect half of the part of their body. So it can be, they will not dress that part of the body. Constructional apraxia, they cannot draw, they cannot copy. You may draw a complex diagram like a column or something. They cannot copy that. Gait apraxia, they find it difficult to walk. The coordination of walking will be interfered with. They can have a gaze apraxia. And there is an apraxia of eyelid opening. Now, this will not, you will not be tested on this in too much depth unless you've been very brilliant in your performance and they want to really give you higher marks or something, and so they may go into this. You can read it up, it's there in all the standard textbooks, but if it's confusing you, leave it, is what I suggest. Just understand that the localization is to the left parietal lobule and it can interfere with examination of a patient with aphasia. But when there's an apraxia of speech, there is a difficulty in our aphasia testing. So it will be a tendency for groping for words or sound. They cannot make speech sounds automatically, easily. They can't put sounds or syllables together in the correct order to form a word. Their speech movements and will be, they will not be coordinated. They can make a lot of errors. So it can actively interfere in your getting a proper evaluation of a person with aphasia. Now, in recent years, thanks to technology, they've gone further and identified that certain speech functions can be further localized. So it has been found that this part of the brain is responsible for mediating verbs. This part of the brain is for noun generation. This part of the brain helps form words and sentence implementation. So this is just to tell you that now we are becoming more and more micro-localizing and we are able to study the brain as it is doing something through PET scans, through fMRI, etc. And so we are able to understand that, say, color concepts are here. In fact, there is a test called the Luschka color test, which is used in aphasia testing, which tests this part of the brain, which is a visual association area for color concepts. Because sometimes that can also help us to localize the lesion from a bedside exam. But of course, today the MRI and CT have humbled the clinician. We used to say 2 plus 2 makes 4 in neurology in my days. But now we know that sometimes 2 plus 2 can make 6 also. So let us see. Now, when you examine for dysphasia, dyspraxia, dysarthria, or dysphonia, you need to get their occupation, their education, level of literacy, the number of languages known, because we live in a multilingual country, to speak, to read, to write, to understand. Why do we have to know this? Because when we see recovery, sometimes the patient will recover in a particular language alone, even if though they know 2-3 languages. And my research in my PhD, we showed that it will be the most commonly used language rather than the mother tongue. Not necessarily the mother tongue in which they recover. Now, though my mother tongue is Tamil, I use English a lot. And so if I had a dysphasia, my recovery will be more likely to be in the English language than it will be in the Tamil language. So it's very important for us to understand the languages they know to speak, to read, write, and to understand. So you get a routine medical history, do a general mental state, assess the accuracy with which the patient recounts his history, supplement it with the family member's history, and the level of consciousness, alertness. In general, aphasia testing is best done when the patient is fresh. And if the patient is tiring in the course of the aphasia testing, you are advised to abandon the testing and redo it again when the patient is fresh again because their level of performance varies. You have to check for lesions which impair vision. And sometimes in a carotid stroke, you may get the hemiplegia and an aphasia, and they may also be blind in one eye. And I told you about the hemianopia, about cortical blindness. All of these can interfere with your examination of the patient for aphasia. Then you have to also check for, do the normal neurological exam you have to do. I told you how we do the speech assessment, fluency, repetitive speech, and spontaneous speech, automatic speech. A Broca's aphasic may curse suddenly when he has a pain, and you may think, oh, he's got normal speech. That is automatic speech, and that can be intact in a Broca's aphasic. We also check for seriatoms. Tell me the days of the week, tell me the months of the year. That also gives you the fluency, it helps you to access fluency. We've talked about repetitive speech, and what we do is for dysarthria and for this thing, presence of apraxia, you check the phonemes, you check the labials, ba, ma, pa, wa. All of these are labials. The linguals are da, la, ra, ta. So you can say a word like lorry, which will test both those. Then you've got labiodentals, which are the f, s, th sounds. Then palatals, which are na, ringing, that is a palatal. So you need to test for all that because you have to exclude a pulba palsy, pseudobulbar palsy, etc. Then there are a lot of words which you can use, both English and Tamil, bambaram, bambai, palam, all of these, damaram, roti, lorry, all of these can sisa, tukam, all of these test the various components of the peripheral speech apparatus. And there are a lot of sentences which are given in the books which you can use. Object naming, picture naming will help you, body part naming, color naming, object grouping. They group similar, you give them a display of objects, some of them will be similar, you tell them pick out the similar objects. Then you should give them a spoon, a plate, and tumbler, and they have to tell you what is the function of that. A paper, pencil, pen, eraser, and ink. What do you use it for writing? Give them a comb, powder, soap, towel. What do you use it for? Toilet. for toileting yourself. Then you check the mechanics of speech and speech formulation. You have to do this through conversation, interpretation of a story, reading, answering comprehension questions, writing, copying, etc. There are some medications which are useful to improve aphasia. None of them are, uh, tested or tried in a reliable way. But all of us do tend to write it because we feel that if it's helping, it's not doing any harm, it's okay. And the drugs which are usually used are bromocriptine, piracetam, donazepam, and dexamphetamine. There are others which are being tried, but which we cannot recommend. So I hope with this, I have taken you from this to this. And at the end of it, you're going to say, okay, aphasia, I've got it. So I finished on time, 5:45. Now we'll answer your questions if you have any. Okay, guys, come on, wake up. All of you went to sleep or you listened?
Ma'am, we were listening only, ma'am.
Yeah, I'm just joking. Just tell me. So what anybody wants to ask any questions, any doubts? Any repetitions they want? Any portions they want repeated? Okay,
It's clear.
if you don't have questions, I want feedback. Are you clearer now on aphasia? Did you like the class? What did you like? What you did not like also, I want to know, so that next time we can do a better job.
Ma'am, the class was good, ma'am. And the lesion localization part was very nice.
Sorry?
The lesion localization part that you had mentioned in the class was nice.
Yeah.
Ma'am, also on a negative feedback, I think we could have avoided a lot of history, which is, I don't know if it is significant for us, ma'am. The
No, it's all
history of,
right, because the tragedy of today's teaching is that none of you are being told history. You should know how this
okay,
knowledge came, because we stand on the shoulders of the masters of before.
yes, ma'am.
How many of you know the history of neurology in the city? I'm sure you know nothing. You don't know anything.
Ma'am, it would be
You
nice if you
should
would share
know.
your personal experience now.
My personal experience, I joined DM neurology by accident. I didn't want to, I was terrified of neurology when I was in final year MBBS. During my MD, I did my neurology. Okay, I liked it, but I was not very enamored enough to go and do DM neurology. But it so happened that my first service posting was in Institute of Neurology, MMC. And so, since I was already working there as an assistant professor, and those days you could do you could apply as a service candidate, I said, okay, let me also pick up a degree in the process. That is how I joined DM neurology. But once I was doing that, I got very fascinated by aphasia. And so I started doing a PhD in that. And I evolved a bedside diagnostic test, which is simple and which gives localization. At that time, CT scan had just come, the CT had just come to institute. So there were a few cases which I could verify whether my localization and the CT localization were similar. Also, while I was doing that, this multilingualism thing caught my fancy. And I realized that all of us know more than two languages minimum. And all of us use our languages differentially. I'm sure you're familiar with the fact that many people we know, when you ask them to calculate something, they'll break into the mother tongue. They may be thinking in English, talking to you in English, but they'll suddenly say, Amama, they'll start talking in the vernacular. So I analyzed that and I found that there is a task oriented use of language. For some tasks, we use one language, for some other tasks, we use a second language, a different language. Also, we do something very peculiar called code switching. We'll mix Tamil and English into a sentence and make it grammatically correct and understandable to the other person. Yes?
Yes,
We
ma'am.
do that all the time, don't we?
Yes, ma'am.
So the code switching was something that I made a note of and said, it's perfectly understandable to the other person, though I've used a mixture of English and Tamil words. And grammatically, it will be correct also in its own way. So semantically and syntactically, it works out to be correct. And then I found that when I applied all this onto my aphasic patients whom I was examining, the language which recovered most quickly was the language they were using maximally. And the language which was last to go was the language used for calculation and for deep personal prayer. When you talk to God, in what language do you talk to God? And we found that those two used to stick on. They were right hemisphere functions which were not going away. That was a very interesting phenomenon. And the language which first recovers first also is the language used for thinking. Though throughout at that time, the literature was saying the language you recover is the mother tongue. Then I also had to point out that in India, we have a different way of absorbing more than one language. The way you learn a language can be compound or coordinate. Now, coordinate languages, I speak Tamil, I go to school, I learn English, then I go to middle school, I learn French as another language or Hindi as a third language, like that, systematic one after the other. That is called coordinate learning. But that's not the case with most of us. My father may speak Telugu, my mother may speak Tamil, the maid who looks after me may speak Hindi. I go out and I speak English and Tamil in the public. Isn't this common in our atmosphere? So that is called a compound way of learning language. And when you learn language in a compound way, it's more robust than you learn this way. So I've had a patient with aphasia who's a Hindi teacher. She's a Tamilian. She teaches in English, and she's a Hindi teacher. And she's Tamilian, she talks Tamil at home with everybody. But when she got aphasia and recovered, she recovered Hindi first. The importance of this is I had to give her speech therapy in Hindi because it was important to retrieve one language at least in totality for her to be able to function, live her life. But then as she was almost perfecting her Hindi, the Tamil came back. Tamil started coming. So the reason why we need to give some importance to multilingualism, especially in our population, is because we can help them to recover. Because if you bombard the brain when it's recovering with multiple languages, it's not going to do any language. So it helps us to choose which language to give speech therapy in. And many people ask why I did neurosurgery as well. As I was a practicing neurologist for some time, I began to feel quite useless because 30% of neurological disorders have got fancy names, lot of disability, and at the end of it, we do fancy tests, expensive tests, and then we say, sorry, there's nothing I can offer you. So I've been quite frustrated with that. Then I realized that epilepsy would be a good area to go into. I trained myself more and more in epilepsy, started focusing on epilepsy, started an epilepsy center in 1994, celebrated 25 years of that last year. And I wanted to do epilepsy surgery as well. When I asked my surgical colleagues, they said you will be referring 4 or 5 patients a year. That is not going to give me bread and butter. Only the tumors and trauma will give me bread and butter. And I too was getting bored. I was in Apollo hospitals as a consultant, but I love teaching and I didn't have any academic stimulation. So I said, okay, there was an advertisement which said DM Neurology can apply. This was created especially for a particular person who had power with the chief minister of the time. And they never expected somebody else would apply. So just for the fun of it, I applied. I went back and studied basic sciences because the entrance exam had a lot of basic sciences. This was in 86. I finished my DM Neurology in 78. Went back and read basic sciences, wrote the entrance exam, stood first in the entrance exam. And I got the seat. And there were many times when I was doing my MCH in neurosurgery when I used to think, I've gone crazy. Why am I doing this? Why am I torturing myself like this? Because whole day I'm PG in MMC, doing all the dirty work, including indent writing, starting drips, writing case sheets, etc. Evening, I'm consultant neurologist in Apollo Hospital. It was a very interesting period anyway. So managed to pass my MCH also in the first attempt. And then started epilepsy surgery in Apollo Hospital in 1998. So that was why I became a neurosurgeon also.
Ma'am,
Tell me.
ma'am, can you please check the chat in on the bottom half of the
I'll
screen?
check.
Maybe there might be
Yeah,
person
okay,
private
yeah.
questions.
Repetition intact. Any doubts? Excellent, ma'am. Dr. Suchitra says. How to test the dormancy? Okay, we'll do that. Handedness. Now, it's not only handedness which is important. Okay, it is also tonguedness, leggedness. One of the ways to identify handedness in a very simple way is to tell the person to do this. Okay, just do this. All of you do this and see which thumb is on top, left or right. Which thumb is on top, left or right?
For me, it's left, ma'am.
Left.
Okay.
Left.
For me, it is left. Okay. I was left-handed, changed to right. So Basically, that is probably the reason why I'm sort of equibrained a bit in my way of doing things. That's one way. Another way is to see the Venus pattern on the dorsum of the hand. Usually, the pattern will be very well formed on the dominant hand compared to the non dominant hand. The other thing is that you throw something at somebody and see which hand they catch it with. Leggedness is tested by keeping a ball and seeing which leg they kick it with. So tonguedness is more difficult to test, that's okay. But handedness, and that will give you the dominance. So if you're right-handed, 99% you will be left brain dominant. Whereas if you're left-handed, there is a 12% chance you may be right brain dominant, but most of the time you will also be left brain dominant for language. Does that answer your question?
Also, there was a question somebody sent to me in private chat.
Yeah.
Can you summarize the clinical localization of aphasia, ma'am?
Actually, you guys must do it. Then only I'll know whether what I taught you is worthwhile or not. So
Okay.
clinical localization of aphasia, nothing. First, as soon as you see the patient, when you start talking, the way I do it in the consulting room, I'll tell you. So I see whether it is fluent or non-fluent. Straight away, it gives me an indication. Then I just allow the patient, ask the patient to talk, spontaneous speech. If the word output is good, it is a posterior aphasia or a receptive, likely to be a sensory aphasia. If the word output is low, it is an anterior aphasia or Broca's transcortical motor, that category. It becomes an anterior aphasia. Then we ask the person to repeat. If repetition is intact, it's beyond the perisylvian region. If it is impaired, it is in the perisylvian region. If the person has not been able to understand any of my instructions, it's a comprehension problem, then it's a receptive aphasia, not an expressive aphasia. And in the receptive aphasia, if there are a lot of paraphasic errors, they keep garbled, nonsense, there's no meaning at all in what they're saying, chances are it's a Wernicke's aphasia. If whatever they say has meaning, but it is just word finding difficulty and low word output with full understanding, it's a Broca's aphasia. Of this, if the repetition is impaired, it either becomes a transcortical motor or a transcortical sensory. That's more or less what we do. After that, we go into in-depth testing as to whether there's agnosia, apraxia, and a reading writing analysis. So have I disappointed you or lived up to your expectations?
No, ma'am, it's clear now.
Yeah. Okay, somebody says they like my career and my class very much. Thank you. Anything else? Anybody else? Can we close? Dead on time, 5 to 6, 3 to 6.
I think so. And
Yeah, you formally close the session, Fida.
yes, ma'am. I'll ask the host.